and we will discuss it on nearest class. So pancreas hormones like insulin and diabetes mellitus and the treatment of different types of diabetes. And just for note, please tell me, now do you see a second slide? Because I'm using...
Yes, ma'am.
Yes, doctor, we see it.
Okay, great. Sometimes there is problem with full screen, and I know any teachers give a lecture from program window. Okay, I think it's better. Diabetes mellitus, I think you heard about this disease. It's a chronic disease, and causes of it usually is deficiency of insulin production, and sometimes insulin tolerance or ineffectiveness of insulin produced. And like main symptom, high level of glucose blood, and this high concentration of glucose might be causes of any complications or secondary damages of different system and organs. And so the goal of treatment decrease glucose level in the blood. Generally, like 400 million adults have diabetes in the world, and a lot of deaths of people are directly attributed to diabetes every year or each year. And like example, in India, 65 million patients. It's more than 8% of world people, world patient, and it is a really big problem. First of all, as I said, because diabetes might be causes of different complications. I hope you remember insulin like main hormone of pancreas produced by cells of islet of Langerhans, and there are a few types of cells. Beta cells exactly produce this hormone, and just for note, if you don't remember, other types of cell like alpha cell produce different substances like glucagon, or D cell, delta cells produce somatostatin, and there is not a lot of another secretory products. As you see, like 75% of all and any other substances like C-peptide or proinsulin. And first of all, if there are any damage of pancreas, so it might be causes of diabetes because there won't be produced this hormone. Also, just for now, because I really hope you remember it from previous courses from previous year. Insulin effect on different processes and different substances, not only on glucose level, but for us, glucose level decreasing is the main thing in diabetes therapy. But also, insulin increase glycolysis, increase glucose uptake in muscles and adipose tissues, and increase or stimulate protein synthesis and uptake of ions, especially potassium ions and PO4 ions. But from another side, this substance decrease or block lipolysis, proteolysis, gluconeogenesis, glucogenolysis, and ketogenesis. Sometimes we may influence on glucose level directly, so increase glucose, increase insulin level, stimulate glycolysis, but sometimes we may use indirectly, and we may use different effects of insulin, like blockage of gluconeogenesis, for example. All these effects are important, of course. And a few words about types of tissues. There might be insulin-dependent tissue like a muscle or adipose tissue or liver, and they can uptake glucose only in presence of insulin. And if there is not enough insulin in the human body, so these tissues will be damaged first. And there are a few insulin non-dependent tissue, like nervous tissue, of course, kidney, endothelium cells, intestine cells, and beta cells of pancreas. They free glucose uptake because the cells produce this insulin. Sometimes insulin-dependent tissues may use alternative sources of energy if there is no insulin. And in this situation, fatty acids also might be metabolized, and it's not, of course, a big problem, but it's not usual endogenous processes in the human body. In this situation, lipid metabolism will be changed a little bit. First of all, should be increased synthesis of fatty acids in the liver, because more these acids will be metabolized by insulin-dependent tissues. In this situation, will be decreased lipolysis in adipose tissue, because insulin-dependent tissue need more fatty acids, and will increase synthesis of glycerol in adipose sites. So, like a final result, there will be fat storage for usual work of insulin-dependent tissues. Protein metabolism also will be changed, will be decreased, of course, and will be increased. And of course, will be decreased proteolysis, like opposite process. These effects of insulin are produced with different speed, like a very fast effect, increasing glucose and ions transport into the cells, a little bit more slower, like a fast effect, increasing glycogen, fat acids, and glycerol and protein synthesis. More slow, and it might be called slower effect of insulin, increase enzyme synthesis and decrease catabolic enzymes. And very slow effects increase cell division. Of course, if we talk about insulin like a drug, first of all, very fast effect is the most important. And in dependent response of tissues to insulin and depend on production of insulin, there might be divided two types of diabetes mellitus, type 1 and type 2. First type might be called insulin-dependent diabetes mellitus. Second type, non-insulin dependent diabetes mellitus. And actually, I know sometimes diabetes mellitus might be called just diabetes and not necessarily tell full name diabetes mellitus. First type diabetes, second type of diabetes. So your colleagues, of course, will understand you. And a few subtypes, not official, but also you should know about them. Impaired fasting glycemia, impaired glucose tolerance, gestational diabetes mellitus or diabetes mellitus in pregnancy, and secondary diabetes. There are different causes, and it might be result of any other disorders. First of all, like any damage of pancreas or any surgery or any trauma. And if there is not enough production of insulin, yeah, there is diabetes. Next thing, symptoms of diabetes. So how could you diagnose it, and how should you know your patient has a diabetes? First of all, main part of symptoms, three P's might be called polyuria, polydipsia, and polyphagia. I suppose you know this term from internal diseases or from therapy. And actually, I'm not sure you have a therapy classes, but you absolutely have internal diseases classes. But if you don't know polyuria, urinary frequency, very thirsty, it's polydipsia, and polyphagia, very hungry. Your patient very hungry. And if your patient or maybe any person who knows you told you about these symptoms, so first think about diabetes. And just to be sure, dryness of mucous membrane and skin, fatigue and weakness, weight loss, especially for diabetes type 1, fungal infections or any other infections, and leg pain and impotence or decreasing of libido. And of course, these symptoms are typical, but they are typical for different disorders. You couldn't be sure based on these symptoms, patient has a diabetes. Main thing, it's blood glucose test. And there are a few types of tests. Fasting blood glucose test show you amount of blood in special volume of blood. So if there is less than 6 or 6.1, it's a normal. If there is 6.1 to 6.9, or you may from 6 to 7, it's easy to remember, impaired. But if there is more than 7 millimole per liter, so it might be diabetes. Casual blood glucose test. So you see if there is 11 millimole per liter plus all the symptoms, you also may be sure it's diabetes. And second type glucose tolerance test. And oral intake 75 grams of concentrated glucose solution, and normally blood glucose level return to normal within 2 to 3 hours after this injection. If after 3 hours, for example, and actually it's like a meal after any food, after taking any food, so glucose level should return to normal. And if there is no, so there is not enough hormones, and it might be proof of diabetes also. One more test, glycated hemoglobin testing, and urine tests presence glucose. It means glucoseuria and presence of ketone bodies, ketonuria. Also used in diagnosis of diabetes, but 3 types are more important. And a few words about type 1 diabetes. First of all, usually this type of diabetes will be diagnosed in childhood or between 10 or 15 years, because if there is any problem with pancreas, if there is any damage, sometimes genetically problems, so doctor will see it, and if there is any damage of pancreas, also type 1 diabetes will be diagnosed. And usually patient has all these symptoms from childhood, and of course it's causes of any special tests. What happens if there is type 1 diabetes and if there is not enough insulin production? First of all, amount of insulin decreased in the blood cells. After that, like compensatory will be increased glucose level, because it could be decreased by insulin. And if there is increased glucose level and muscles like insulin dependent tissue couldn't use this glucose because there is not enough insulin, and glycogen and protein breakdown causing ketoacidosis and any other damages of tissues. Type 2 diabetes, like non-insulin dependent, might be result of any other factors. First of all, also genetic factors, but obesity or any viruses or autoimmune diseases and peripheral insulin resistance also may be causes of type 2 diabetes. In this situation, beta cells produce insulin, but not enough, and in this situation, any other processes like I told you before, insulin influence on different processes, protein, dependent protein, and in adipose tissues, and all these processes also might be affected, and like a result, decreasing of or increasing of glucose blood level. So almost the same scheme, but different causes. Sufficient insulin secreted in the bloodstream, and glucose level increased in the bloodstream, sometimes because of insulin resistance, and muscles also unable to use glucose, but not because of there is not enough insulin, because there is insulin resistance, and like causes like a result, obesity and other factors leading to insulin resistance. Lifestyle also may influence on this process, but insulin resistance, like a problem, might be causes of different complications. Cardiomyopathy, increase of intra-abdominal fat, hypertension, inflammation on the liver and cirrhosis, increased blood clots risk, atherosclerosis, and different things. So, like a summary, comparison of two types of diabetes, different age of onset, different nutritional status at time of onset of disease, prevalence, it means second type of diabetes or non-insulin insulin-dependent diabetes. More common maybe. So like 90% of all diagnosed diabetes, it's type 2. Genetic predisposition, also non-insulin dependent is very strong predisposition, and there is high risk to have diabetes if parents or grandparents had it. And effect of deficiency. For type 1, as I said, damage of beta cell or destroying of beta cell. And for second type, inability of beta cell to produce appropriate amount of insulin or insulin resistance. One more thing, there are a lot of complications of diabetes mellitus, and even the patient has therapy, take drugs, so any complication are possible, and most dangerous acute complication is diabetic coma. There are 4 types of diabetic coma: hyperglycemic, it means high level of glucose; hypoglycemic, hyperosmolar, and hyperlactacidemic. Just for note, hyperglycemic coma might be if there is very high level of glucose in the blood, more than 20. As you remember, if there is more than 7, it is diabetes. Now there is 20 sometimes, and of course it is coma. Progressive dehydration of the organism, so excretion a lot of water and not enough taking of water. Ketoacidosis or metabolic acidosis, it might be diagnosed with a typical acetone smell from the breath. Inhibition of CNS activity, decreased arterial pressure, and tachycardia and extra systolia. Hypoglycemic coma, it's the opposite condition. If there is too low glucose level, and the patient become agitated, sweaty, there is activation of sympathetic nervous system or adrenergic nervous system, and the consciousness can be altered. For first type, for hyperglycemic coma, patient needs hypoglycemic drugs like insulins or oral hypoglycemic drugs, dependent type of diabetes. For hypoglycemic coma, patient needs any food or sweet drinks, or sometimes if patient unconsciousness, so it's severe case, injection of glucose, for example, intravenous infusion of glucose solution. Hyperosmolar coma, third type of acute complication. It is a high concentration of glucose and sodium and chlor and bicarbonates, ions, and urea in the blood and ammonia in the blood, and because it's abnormal high concentration, so it might be causes of disturbance of consciousness. And of course there is no acetone smell from the mouth, but influence on breath, short breath, and tachycardia and heart rate disturbances, and also should be how to explain. So patient should be hospitalized in this situation. And hyperlactidemic, lactacidemic coma, it's not often rare complication, and usually in elderly people suffering from any other diseases. Chronic complication, it means they might be produced after long period of time. First group of this complication, diabetic retinopathy, problem with vision, severe vision loss or blindness. Diabetic neuropathy, like example, diabetic foot and any problems, any damages of blood vessels to the foot. And diabetic nephropathy, so problem with the kidney or renal failure. Just for notes, so this is eye, and damaged blood vessels might be causes of diabetic retinopathy. And this is damaged of vessels in the foot and gangrene of the foot, so like chronic complication of diabetes mellitus. And in this situation, I mean, if patient has I was saying, you as a doctor should warn your patient, and he or she should be careful with any foot damages, because it might be causes of very dangerous complication. Any other chronic complication like macrovascular, it might be coronary artery disease or heart attack, myocardial infarction or angina, stroke, and peripheral vascular disease, which contributes to diabetic foot. Diabetic foot may cause necrosis, infection, and gangrene, as I showed you. And there is half of class, and I would to start tell you more specific about treatment of it. So just for note, if you other complication like cardiomyopathy, you saw it in slide with the complication of insulin resistance. All of them were in the same slide. Any infections and therapy of diabetes consist of maybe 3 different parts. And you couldn't say there are three ways of therapy, because usually all these way of therapy at the same time, so used together. First of all, diet therapy, drug therapy, and physical activity. A few words about diet therapy and physical activity, because it's logical actually, and a little bit more specific about drug therapy. For diabetes type 1, patients should have meals 6 times a day, and there is no, of course, sugar, any sweets or honey, and better to not use alcohol, just 20 grams a day, and of course not every day. For diabetes type 2, have meals 3 or 4 times a day is recommended. Physical activity is effective because muscles use more glucose, and muscles need more energy, and they use more glucose in presence of insulin, of course, and in this situation, glucose level will be decreased also. And pharmacotherapy. So actually main thing of our lecture, because it's pharmacology and we're talking about drugs. There are two main way of treatment. First of all, different drug of insulins, and second type of drugs, oral hypoglycemic drugs. And insulins used for treatment diabetes type 1, because there is not enough, there is no insulin production, and patient should take exogenous insulin. Oral hypoglycemic drug used usually for diabetes type 2. And insulins will be subdivided just based on duration of action. There are rapid action or short-acting drugs, intermediate-acting drugs, and long-acting drugs. They produce very slow effect. Oral hypoglycemic drugs are classified based on chemical structure and based on mechanism of action. I really recommend you take this screenshot if you have no pharmacology at a glance by Neil, because here you see all classes of anti-diabetic drugs. First of all, insulins and oral hypoglycemic drugs, their mechanism of their action, and a few words about long-term complication, why they are produced, and actions of different oral diabetic drugs. Like biguanides or glitazones. First of all, I would say about insulins, and I wouldn't tell you again about structure and effect of insulins. I'm afraid there is not enough time, and you really studied in biochemistry. It is a polypeptide hormone. There are two peptide chains, and they are connected by disulfide bonds. And effects of insulins. Wouldn't say it again. Yeah. About drugs. There are different sources of insulin for diabetic patients. First of all, we may use beef or bovine insulin. It differs from human insulin by 3 amino acids, and we may use porcine or pig insulin. It differs from human by only 1 amino acid and produce a less immunogenic effect. There is no big difference. Bovine insulin produce sometimes immunogenic effects, so it might be causes of immune response in the human body. So they are not totally safe, but they very helpful for patients. And of course, scientists try to reduce this immunogenicity and better to use monocomponent insulins. So insulin preparation obtained from beef and pork pancreas, and if they will be purified, so if there are no different substances like proteins or proinsulin or any fragments or parts of these molecules, they will be produce less immune response, and they will be more safe. Sorry, they will be safer for patients. But better to use insulin produced by recombinant DNA technology. In this situation, any insulins, of course, purified insulins, how to explain? So scientists use these molecules and enter them to bacterial cells, usually Escherichia coli or E. coli, and after this, maybe better to understand using the scheme. So this is human DNA, insulin, and bacterium. And if we changed bacterial DNA and switch part of bacterial DNA to insulin gene production, so this bacteria will produce specific insulin by this recombinant DNA, because bacteria has recombinant DNA, and this insulin wouldn't be like human insulin, and there is no immunogenic, there is no immune response, and it's totally safe for patient, and of course produce effect like endogenous insulin. But there is one more problem. Insulin doesn't matter what source of insulin. It is a polypeptide, and this polypeptide will be destroyed in the stomach by acid. So all insulins might be administered by injection, only by injection. In this situation, there is no influence of stomach acid, and this hormone may produce effect. Usually we use subcutaneous injection, but if a patient has hyperglycemic coma, hyperglycemic emergency, this insulin might be injected intravenously, because 100% of viability, the fastest onset, and for emergency it's better. Insulin drugs or insulin preparation, they are subdivided into few classes, depend on duration of action, and sometimes patients should take a few injections in a day, and it's not convenient for patients sometimes. So scientists also will discover new devices or new ways of administration of insulin. I will tell you about it few minutes later. At first, about classes or types of insulin. Rapid onset or rapid acting insulin, the fastest drugs, and they start working like to 15 minutes, and peak time, it's about 1 hour, and duration of action from 3 to 5 hours. Novorapid or insulin aspart Humalog, Lispro, like example of rapid-acting insulins. And better to use special insulin pens. It's easy to take an injection. Short-acting insulin, like second class of them, have 30 minutes onset and peak of effect on like 4 hours, and total duration of action like 6 hours. Humulin, Actapid, like examples. Third subclass of insulins, intermediate acting insulins. And actually it is short acting and intermediate acting are most commonly used classes of insulin drugs. Starts effect after 90 minutes, it means onset, peak at 4 to 12 hours, and duration of action for 16, usually sometimes to 20 hours. Humulin, NPH, and actually NPH means intermediate acting drugs. And there is long-acting insulins like glargine or detamir. There is no peak because they work constantly and release need amount of substance in bloodstream. Total duration of action like 24 hours, but sometimes better to use mixed insulins. It's a combination of insulin with different duration of action. Usually it's short-acting drugs and intermediate-acting drugs. Short-acting drugs like 30%, 70% of intermediate-acting drugs. And usually you may see amount of substances in the name of insulin drug, like mixed at 30 to 70 or 20 to 80. It means 20% of short-acting drugs and 80% of intermediate-acting drugs. And actually, it might be called, it might be written in the pocket in the drug, just amount of short-acting. Why it is not better? Why it's more convenient for patients? Because short-acting drug produce very fast effect, of course faster than intermediate, but after end of action, short-acting drugs, so intermediate acting produce their effect. In this situation, patient has very fast effect and effect to 12 to 16 hours. It's better because in this situation, patient should take just 2 injections in a day, and it's more convenient. And this is a funny picture about main characteristic of insulins, like, and I'm saying you again, there is onset, peak time, and duration of action. There are 3 main characteristics of insulins. And what I said you about mixed insulins and replacement therapy. If patient take short-acting drugs, for example, before breakfast, there is a increase in concentration, decrease in concentration, and after next meal, patient should take 1 more injection. So totally 3 times in day, and there is no stable concentration. If we're talking about combination therapy, you see there are 2 peaks after 1 injection. First peak of short-acting drugs, they are 30 or 20% in the dose, and so peak like I don't know, 9.5 maybe. And at 1 p.m. there is peak of intermediate acting drugs in combination. In this situation, patients should take injection just twice. And I'm saying you again, of course, it's better. Because of it, mixed insulin generally is the most commonly type of insulin preparations. And sometimes might be used special pumps, insulin pump, special device. There is insulin. There is a needle for insulin infusion and a special sensor what control glucose level. And in this situation, patient shouldn't take glucose test and shouldn't take a special injection. Just wear this pump and like automatically this device control glucose level and give any insulin infusion if necessary, if it needs. It's of course it's better, but this device is more expensive and not all patients may use it. So insulin pens and usual injections also like a popular. A few ways of treatment: standard and intensive. Standard treatment versus intensive treatment. Standard treatment, as I said, twice a day, mixed insulins, and finally, glucose blood level, it range from 225 to 275 milligrams, and it's like normal. If there is any intensive treatment, so there is more times daily, like 3 or sometimes more than 3. And of course, a patient should control glucose level. In this situation, glucose level like 150 milligrams, and sometimes it more effective, but depend on situation and patient history. If patient has a hypoglycemic episodes or coma or seizures due to excessive insulin, so there is a intensive treatment regime. And patient with intensive therapy shows 60% reduction in the long-term complication of diabetes, retinopathy, nephropathy, neuropathy, if compared to patient receiving standard care. So you as a doctor will select the most appropriate regime of therapy. Of course, any drugs produce side effects, and insulin drug used instead of endogenous insulin, but also produced hypoglycemia, of course, because decrease blood pressure, and it might be causes of weight gain, lipodystrophy, allergic reaction. Even patient use not purified insulin. Symptoms of hypoglycemia, how to easy remember this: fast heartbeats, sweating, anxious, dizzy, hungry, fatigue, headache, and blurry vision. And hypoglycemia might be treated very easy. Patient should eat something sweet. Second way of therapy of insulin, it's oral hypoglycemic drugs. As I told you, this drug used for treatment diabetes type 2. And I don't understand where are the students, because in the beginning of lecture you were It's about 90, now just 50 students. I try to make this lecture interesting. If there is any bad connection, let me know. And yeah, as I told you, I'm taking a screenshot and send it to your lecture. Okay, drugs for treatment diabetes type 2. There are few actions of few sides of action for this drug. First of all, we may increase insulin secretion from beta cells, like sulfonylureas. Sorry. No, I showed you the main classification. Yeah, insulin secretagogues or drugs what increase insulin secretion, like sulfonylureas and incretin enhancing agents. We may decrease gluconeogenesis. Sulfonylureas also influence on it, but big guanides influence more. We may increase glucose absorption, like acarbose or big guanides or incretin enhancing agents. And also we may increase insulin receptor sensitivity and big guanides, insulin, like insulin of course, and sulfonylureas may influence on sensitivity to sensitivity of receptor to insulin in body cells. First big class drugs what increase secretion of insulin. They might be called insulin secretagogues. There are two main classes, sulfonylureas and meglitinides analogs. First group, sulfonylureas, might be subdivided into three generations. Don't be surprised if you read in your textbook about two generations, like usually I must say different authors suggest different classification. Sometimes glimepiride from third generation might be included in second generation drugs, but it is the newest drug. Drugs from first generation like chlorpramide, second generation glibenclamide or gliquidone or glipizide or gliclazide. They have almost the same drug names, and also it's usual thing for classes of drugs. Don't be confused with these drug names and try to remember them really. And drugs from third generation, as I said, glimepiride sometimes might be included in second generation. How do they work? First of all, they stimulate beta cells of the pancreas by blocking ATP sensitive potassium channels, and like a result there is depolarization and calcium ions influx. Like a final result, increasing insulin releasing from pancreas. Next step, reduction of hepatic glucose production. Not next step, next way. And final way of effect, increase in peripheral insulin sensitivity. And don't be surprised, you saw sulfonylureas in different sites in previous scheme. They indicated in patients who are near the ideal weight, if there is no any weight problem, and glipizide and gliclazide drugs from second generation have a short half-lives, and usually or commonly tried first in therapy. They might be causes of hypoglycemia or glycemic coma. And just for note, it is most common side effects of all anti-diabetic drugs. Might be causes of hyperinsulinemia, because releasing of this substance increased, so sometimes increased too much, and a lot of insulin might be in blood. Hypoglycemia, gastrointestinal disturbances, weight gain sometimes, and any rashes. And main thing, this class of drugs or subclass of drugs is contraindicated in severe hyperglycemia, and any situation, then insulin should be given. For example, any surgeries. Second subclass of drugs which increase releasing of insulin, miglutinide and Alex. Ribaglinide, nataglinide also had almost the same name, and because they include the same class, they also influence on releasing of insulin from beta cells of pancreas. They have very rapid onset, short duration of action, and also if a doctor decided to start therapy with sulfonylureas or miglutinil and Alex, short-acting drugs used first. This drug might be combined with metformin or glitazones. They are drugs from different big class of anti-diabetic drugs. And combined therapy more effective than monotherapy. And these substances never used in combination with sulfonylurea because they have the same mechanism of action. Also, just for now, because you have MCQs about glyburide. This substance has maximum insulinotropic potency and half-life only 1 or 2 hours, but its effect persists beyond 24 hours. First of all, because this substance produces active metabolite, and secondly, this substance binding to sulfonylurea receptors at the cell membrane and gets sequestered within beta cells of pancreas. Interesting drug, and please also take a note about it. Second big class of oral hypoglycemic drugs are insulin sensitizers. They increase sensitivity to insulin. There are two big classes, biguanide and glitazones. Official names of glitazone, thiazolidinediones. And I know students don't like this name, better to use glitazones, but please don't forget there are two names of this class. Thiazolidinediones used in scientific articles, but drugs end in glitazone, so because of it they have a second name. Main drug from biguanides, it's metformin, and this is the most commonly used anti-diabetic drugs. This substance acts peripherally to increase glucose uptake. It doesn't influence on beta cells and doesn't influence on releasing of insulin, so less produce hypoglycemia, but also it's possible. And if patient has any weight problem, so it might be used also. How does it work? Increase tissue glucose utilization, inhibit hepatic gluconeogenesis, also inhibit lipogenesis, and decrease absorption of carbohydrates in the intestine. Like a final result, decrease glucose blood level and decrease appetite, so may control a weight of patient. There is not typical effect hypoglycemia, but also possible. Nausea, vomiting like general side effects, diarrhea might be after taking metformin, and potentially fetal lactic acidosis, but very occasionally. If patient has any renal or hepatic problem, this drug couldn't be used because it influences on liver, for example. And if patient has myocardial infarction or any infections or diabetic ketoacidosis, also better not use this substance. And glitazones, as I said, pioglitazone, rosiglitazone, all drugs end in glitazone, because of it they have a second name. These drugs included the same class, so they influence all, they act almost like biguanides, but rosiglitazone was associated with increased risk of myocardial infarction, and also contraindicated if patient has any problems like this. Glitazones are recommended as a second-line alternative for patients who fail or have any contraindication to metformin therapy. Abnormal liver function, like one of the most dangerous side effects, because they influence on gluconeogenesis in the liver, and also how to say, because they almost like biguanides, easy to remember about them, but this class is the main for treatment diabetes, as you see. Alpha glucosidase inhibitors like acarbose has a different mechanism of action. This substance inhibits glucosides in the intestine and hydrolyze oligosaccharides to glucose. Finally, will be decreased absorption of carbohydrates from the intestine, and glucose level will be decreased. Diarrhea, abnormal cramping, and sometimes hypoglycemia like side effects for this class of drugs. One of the newest classes of drugs, DPP-4 inhibitors. First of all, you need to remember what is DPP-4. It is dipeptidyl peptidase 4, and this is special enzyme what produce destroying or degradation of GLP. GLP, glucagon-like polypeptide 1. This is endogenous substance what influence on glucose level. And all these substances end in gliptin, like sitagliptin, saxagliptin, vidagliptin, linagliptin. Sometimes they might be called like gliptins. And also produce general side effects like headache, nausea, diarrhea, hypoglycemia, like a typical side effects for anti-diabetic drugs, and any infections of upper respiratory tract. Glucagon-like receptor agonist. So substances what influence on GLP receptors, like exenatide, lixenatide, produced hypoglycemia like a typical substance, typical side effects, and dyspepsia or GIT disturbances. One more thing. Different drugs may raise or lower glucose concentration in the blood. It means there are possible any interactions between glucose level and different drugs what patient may take for treatment different disorders. I recommend you pay attention on this or maybe take a screenshot because usually we discuss about contraindications and you as a doctor should prevent any dangerous interaction between drugs. For example, beta agonist like beta 2 agonist like salbutamol, albuterol for treatment asthma, for example, will increase blood glucose level. Glucocorticoids or generally corticosteroids will also increase it. Oral contraceptives. If your patient has a diabetes, if it's a woman, you need to warn about this possible contraindication and maybe your patient should choose another way of contraceptive drugs, another way of contraception. Thiazide diuretic, thyroid hormones, and atypical antipsychotics. So this drug increase blood glucose level and it means you should increase the dose of anti-diabetic drugs or select more effective anti-diabetic drugs. From another side, from another hand,